over the next half an hour or so. But like I say, please jump in at any time, and hopefully there'll be a bit of time at the end for some questions. And I'm sorry this has started a little bit late. So I'm a reader in neonatal medicine now, actually, and a neonatologist at Chelsea and Westminster Hospital and Imperial College. My research is going to have a relatively unashamed neonatal slant to it, where I presume that not everyone on the call is a neonatologist, and that is okay. I didn't want to be a neonatologist at all until I became, till I got to kind of ST4-5. So I'm well aware that these things change as you go along. And interestingly, at that point, so after my first ST3 years, or SHO years as they were back then, pre-MMC, I didn't want to be an academic and I didn't want to be a neonatologist. And then that all really changed over my experience of being a registrar, in part largely just because I realized the value of research in informing optimal care. And I guess at that stage, for me, it became really apparent that without research, we really don't know what we're doing. And unfortunately, even with research, if it's not done in a kind of high enough quality way, then often we still don't really know what the best option for looking after a patient or a baby in front of us is. So this is going to be loosely around different ways to get research experience, and I think tied up within that is leadership, because a lot of research really is about leadership. So it's about organizational processes, it's about managing other people and managing something which can sometimes be viewed as a kind of optional extra, which is undertaking research within what is generally in pediatrics and neonatology a busy clinical experience. So we can talk specifically about some of the management styles and approaches. But actually, at the moment, my talk is largely going to be a kind of overview of ways to get some research experience. So before I tell you about how we could do it, I guess it's important to think about why we might want to do it. And for me, the kind of germ, the seed, if you like, that got me involved in research was recognizing that we really need to do good quality research to advance neonatal care. And a good example of this is TOBY trial, which was going on when I was a neonatal SHO, which of course was therapeutic hypothermia. It was led by Dennis Azzopardi and David Edwards at Hammersmith Hospital then, Queen Charlotte's. And it was a national trial, and it really added quite a lot of the evidence to a developing evidence base about the effectiveness of therapeutic hypothermia in babies with hypoxic ischemic encephalopathy. So a condition where there really had not been any active treatment options prior to that. And it was a really great example. I was involved in recruiting patients into it, and it was a really great example of science informing optimal clinical care. And I think that's what we should all aspire to. But unfortunately, within neonatology and within wider pediatrics generally, most actually of what we do and most of the decisions we have to make on a day-to-day basis are unfortunately not informed by trials as good as TOBY. Often there hasn't been a good randomized trial, or there haven't been several randomized trials, or maybe there hasn't even been a randomized trial at all that have looked at that particular question. And so research is really essential, neonatal research, pediatric research, research more widely, to deliver better quality care, to understand and improve care. And I think that's actually been really nicely illustrated by the COVID pandemic, both in relation to trials like Recovery, which of course have demonstrated that we can do massive, internationally important, practice-changing and life-saving research studies actually within this country incredibly effectively and efficiently, but also in vaccine development and the subsequent testing of those in high-quality clinical research studies as well. For you, I think there are other reasons why you might want to undertake research as well. I think beyond the answers to the research, so beyond the kind of results of new therapies or new reasons, just the sheer process of undertaking research has been demonstrated in quite a few studies now to result in better quality of care being delivered by that research active unit. And I think that's probably in part because research active units understand research and they understand the uncertainty in what we do, and they're better at applying research to practice. And probably it's something also about being involved in research studies. And there's quite good evidence in neonatology in particular that being in a research study offers some kind of inclusion benefit, even if you're in the control arm, for example. So you're not getting any kind of new treatment, but just being involved in a trial tends to lead to better outcomes. So research is good for patients, it's good for units, it's good for science more generally. And then of course there is a personal interest. It is obviously on the curriculum for pediatric training. So you need to be able to demonstrate that you are involved in research. And of course it will be evaluated to some degree in your START exam. as one of the competencies about critical appraisal. It's also an important way to enhance your CV, to make yourself stand out. I think, which some of you will no doubt be focusing on a little bit more as you get closer to undertaking your PhD, your CCTs, and thinking about jobs as a consultant. I think to some degrees, quite beneficially, the days have gone when research was the only way that you could really make yourself stand out. I think it's fantastic now that there's been development in management, leadership, quality improvement, teaching, simulation, a whole host of other areas that are equally important to research. And it means that if you're really not interested in research, there's absolutely no reason that you would have to take a higher degree or get some publications. But I still think even if you don't want to do any of that, it's important that you understand how research fits within the context of NHS clinical care. And that's increasingly important for NHS trusts. And in particular, there is quite a lot of money now tied up with trusts, and of course, important reputational aspects for your trust and potentially for your neonatal unit in being a high quality research delivery centre. And potentially there's quite a lot of money that comes both from the CRN and also from commercial studies as well, which are increasingly interested in neonatal care, which obviously comes with challenges and caveats, but overall I think is a good thing. If we want new drugs to be developed, then we need to work with industry to do that. But I'm happy to be challenged on this. So if anyone wants to jump in at this point with any questions or challenge why I think neonatal research or paediatric research is important, please do. So the next question then, hopefully I've convinced you that, that you should be involved in research, paediatric or neonatal research, the next question really is how do you go about it? And I'm going to lay this out in just two really simple ways. The first one is to take part in existing research, and I think this is something that we probably don't do enough as trainees. I think it's an excellent opportunity, and I think there's a new scheme that's been developed and is being increasingly rolled out by the NIHR, which I think it's really important that we try and take part in. That gives an excellent opportunity to be to take part in research and also to gain really important management skills. And then I think the second bit is to think about whether you can develop your own research ideas. And there's a whole host of ways to do this. Obviously, you can undertake a PhD, but there's a whole kind of set of lower hanging fruit, really, which I think are really important and might be worth considering. And certainly that was my route into research. I started out by doing an MSc, just really to get a grounding in evidence-based medicine. And within that, I did some kind of clinical research questions, PICO type questions. I wrote one of them up for Archimedes and realized at that point I wanted to do more research just because understanding and answering research questions was so important. So firstly, how do we take part in existing research? Well, this is the NIHR, and it is one of many diagrams that are out there about how the health research system is organised in the UK. You've probably seen this before. There's a whole different versions of this. It changes periodically, but it's roughly this kind of structure. So at the middle, you've got patients, parents, NHS trusts, universities, doctors, nurses, all working together. And then along the top, there's something called faculty, and there's investigators and senior investigators. So those are the people who have written the grants, got the grants, the professors, the kind of big cheeses, if you like. And then there's trainees. And actually, that can potentially involve almost any of you if you would like it to. And I think this is where the system has changed a little bit. It used to be very much that faculty was only people who are kind of funded by the NIHR, whereas now there is a new scheme to try and encourage other people who aren't necessarily research funded to take part in and support research. And down there on my left, one of those red boxes, there's the Clinical Research Network, or the CRN, which is a huge organisation with an enormous amount of money tied up in it. It delivers research across the UK. And there's a paediatric aspect to it, and within North London there are various paediatric research leaders within the Clinical Research Network. And your trust will be particularly interested in that because it's through that process that money trickles down through the NIHR to trusts, and it enables them to support their research infrastructure through their R&D departments. And that pays for things like research nurses and also other supporting aspects. And that's driven, or there's a complex calculation that's a kind of dark art really, but basically it's related in some way to the amount of research that a hospital delivers, and at the unit level, so within a hospital, each individual kind of department, the amount of money that they will get from the hospital's allocation is also divided up largely related to how much research they deliver. And that's where delivering on NIHR research studies, so studies that fall within what's called the NIHR portfolio, so those are ones that have been adopted or funded by the NIHR, will all contribute to that and will result in future in more research money coming to your department and trust. The NIHR is obviously a massive funder of research itself. So on the right side there, they fund lots of different projects, and I'll talk a little bit more about that a little bit later. And then they have systems which should enable us to feed research back to people on the front line trying to use it. And there's NICE obviously are very much a part of that, and Cochrane collaboration and various other aspects of trying to get research back into clinical care. So that's a broad overview. That's all very good, isn't it? It's all very nice. It's all slightly removed from you delivering frontline clinical care. But actually, I don't think it is. And I think it's really important that you recognize that there are ways to be involved in research and to support research, even if you don't want to do that research yourself. And this is by taking part in existing studies. So usually these relate to multi-center randomized controlled trials. And these will be run by a clinical trials unit in the UK. And there's several. There's the Children's Clinical Trials Unit up in Liverpool, and there's the Perinatal or Neonatal Clinical Trials Unit based at the NPEE, the National Perinatal Epidemiology Unit in Oxford, that have run a lot of the kind of definitive trials in neonatology, like Toby, for example. And they will have a really overarching clinical trial management team of trial managers and very experienced people who are used to running trials. But at each site where a trial is running, and in a multi-center neonatal trial, for example, there might be 30, 40, 50 sites. There will be a local principal investigator who is responsible for making the research happen at that local site. And there are some fantastic neonatal, in particular, principal investigators out there, and no doubt in pediatrics as well. And actually, there's a new program brought in by the NIHR called the AssociatePI scheme, which is a fantastic scheme aimed squarely at clinical trainees like yourselves and allied health professionals, to give them the chance to work alongside an experienced PI to develop some of the clinical competencies and research management competencies that come along with being a principal investigator. And this, I think, is a fantastic way to take part in existing research studies, understand more about research, and build up a bit of a portfolio for yourself that you may be able to take forward to to your consultant post in the future. Even if you don't want to do a PhD or try and get publications, being a PI is an absolutely critical part of fitting research into critical care going forward. And I'm going to just kind of outline very briefly what that means. And it's very much a scratch of the surface, but about what a PI is and what the Associate PI scheme is, because I think this is something that we should really be grasping with both hands. It's relatively new. It's come out really driven by recovery and the recovery trial, but it's being expanded and broadened to include most studies within the NIHR. And I'm very happy to help people support them in any applications for any of the trials that I might be running or that I'm involved in, because I think this is a really important way to get research experience and get trainees involved in research going forward. So the first thing you need to do is identify existing studies. And now this, I'm afraid to say, is very neonatal focused, but these are the kind of existing studies that are currently running in neonatology. There's maybe one or two additional ones as well. Feed1 is a trial that I'm a co-investigator on, that's looking at different feeding rates in kind of moderate preterm babies from day one. There's AZTEC, which is being led by the team out in Cardiff, looking at routine azithromycin to prevent chronic lung disease in preterm babies. Baby Oscar's basically finished now, it's just in analysis, but that was a trial looking at PDA closure. And the SURF-ON looking at surfactant or management without surfactant in moderate to late preterm babies. And there's another study I'm involved in called Tuskin, which is looking to try and develop a trial in the future, looking at timing of stoma closure. And then another trial called TOAST, which is looking at the routine use of antacids in babies with tracheoesophageal fistula and esophageal atresia. And these are all funded by the NIHR, so they're all absolutely possible trials if they're running at a site where you're working, where you could support the local PI if they were taking part in the trial, for example, through the Associate PI scheme. And the other way to find out about trials outside of neonatology, for example, because I appreciate I've not really covered non-neonatal pediatric trials. There's a whole load of other approaches to do that. There's the clinical studies groups in pediatrics and in the subspecialties. There's the NPEU, which has a fantastic website, and the Medicines for Children Clinical Trials Unit. And no doubt you will be aware within your specialty of other trials that are running. So it's important that you look at these and identify which trials are running at your centre, and potentially if there's trials where there is a local PI where you may be able to piggyback on as an associate PI to understand how that process works and contribute to it. So what does a PI do? Why might you want to be involved as an associate PI as a trainee? Well, I think it gives you fantastic management and leadership organizational skills, because it really is about local research management and local research leadership. The PI is the lead person at that site, and they have the legal responsibility for conduct of the study at that local site. Traditionally, it has been the consultant, but increasingly nurses and other allied health professionals are doing it, and the associate PI scheme is really aimed at supercharging that and getting a whole host of other people who've not been PIs in the past trained so that they can take this on going forward. There is a lot of support from the clinical trials unit running the trial, and they will have worked with hundreds of people who are new to being a PI and brought them along and explained it all very nicely. And they have fantastic standard operating procedures, and they're very good at holding your hand through that process. The Clinical Research Network will provide similar support, as will your local R&D office. So generally, this is a way of undertaking a really important role with lots of support. And the Associate PI scheme enables you to do this under the tutelage of also an experienced PI. Generally, PIs will be recognised in the publication. Often that is as an author, and I think that's the direction of travel which is increasingly being adopted. And Recovery, of course, has thousands and thousands of authors in all of the trial publications, recognising the value of everybody who has taken part in the study, one way or another. And I think that's probably going to be the way that many trials work as far as authorship committees go. So this is a good way to get recognised within publications to also get some personal credit for it. And that comment on the right there, I think, is one that I really like. And it just is about managing people and being able to work well within a team, being able to respond to uncertainties, but also to be able to manage groups of people at your local site in relation to a larger overall project, which of course is a clinical trial. So what do you do as a local PI? Well, you help complete so there's a whole host of kind of infrastructure that is required, and a lot of this will be done by the trial applicant. So the things in green here are things done by the person leading the trial, but there are a whole load of local permissions. A lot of this will be done by the clinical trials unit and the lead applicant, the lead of the trial. But there are some aspects down the bottom here, looking at the capacity for you to undertake your research locally, and then confirming it and planning exactly how the research is going to be undertaken. And that's really where the local PI arrives on the scene and helps to deliver the trial. There's local study documentation, which involves setting up and maintaining all the documents. A lot of these are virtual now, operating procedures and making sure that the most recent version of the protocol and the information sheets are being used, for example. Coordinating the local team to make sure everyone's had the relevant background training. There's a kind of training called Good Clinical Practice, which hopefully you should all know all about as clinical trainees. And it's something that you can do online. It's a very simple NIHR-led course that gives you a GCP training certificate, which is pretty important if you would like to take a bigger role in managing research locally. And then, of course, you're trying to coordinate the recruitment of patients, because trials don't happen and won't give us any answers if we can't recruit patients into them. And supporting research nurses usually, and making sure data collection forms are completed, documentation is filled in, making sure consent forms are signed properly. And then the other key component of being a local PI is making sure that serious adverse events are reported through what will be very clear reporting guidelines to the clinical trials unit, who will then go on to report it to other relevant authorities. And there's very clear guidance about what a serious adverse event is and whether it's related or unrelated to the trial intervention. But it's applying those in a very careful, timely manner. So it looks as though you might get all tied up in red tape, but actually it's not as bad as all that, and your hand will be held and you'll be supported very thoroughly by all of the people I mentioned on the previous slide. And so this is the Associate PI scheme. If that is something which has tickled your fancy a little bit, this, as I say, is a fantastic way to get involved in research leadership and set yourself up to be somebody who can support research as a consultant within a neonatal unit or a pediatric department. It's a good way to make yourself stand out from colleagues. Certainly if you have other strings to your bow, this is a good way to tick off some of your research competencies. The Associate PI scheme will allow this to be credentialed, which I think is really important. It's specifically targeted at junior doctors, nurses, and allied health professionals, and it's specifically set up to develop the skills to be a PI in the future. As I said, there is training that goes along with it and formal recognition in the form of certification, and it is designed to support NIHR portfolio studies. And you can go on to the NIHR Associate PI web pages, and it will tell you which studies are out there. I don't think there's very many in pediatrics, but that can change very quickly as there's a very clear way, and I think most trials units would support this associate PI scheme wholeheartedly. So what do you want to do? If you're at a big unit and you know there are trials that are ongoing, the first thing to do, I think, is to find out who the local PI for those trials is and discuss with them. You can then see if the study is registered within the associate PI scheme. And if it's not, there's a very simple process that the trials unit and the chief investigator can do to get it registered. And then you register that you would like to be the associate PI. And then there's a kind of checklist of things that you need to do to demonstrate the involvement you've had with the trial. And at the end of that, there'll be certification. The plan is that this should take about 6 months. So for people who are, for example, on grid training, who are going to be at a unit for a year, or other people who may happen to be at a unit, for example, if you're doing your core SD4-5 training, you may be at a unit for a year. This is a perfect opportunity to undertake this within that timescale. And it may be that you're able to set up a system where people can come in and take that role on going forward. So fantastic. I think this is a really exciting advance, and I would strongly encourage people to look into it, and I'm very happy to support people and talk about that if anyone has any questions about it. Within this is good clinical practice. I mentioned this very briefly a minute ago. It's a kind of formal process recognizing that there is some training to take part in clinical trials. It covers all of the kind of international scientific, ethical and practical standards. It's really focused on protecting the rights and well-being of trial participants and ensuring that results to trials are accurate and credible. Everyone really who wants to take any kind of role, particularly leadership or a management role in research, needs to have this training signed off. And it's a legal requirement for trials that are looking at investigational medical products, which is basically drug trials. So any drug trial, absolutely everyone involved in that will need good clinical practice training. It's available free through the NHS in UK. And if you just search NIHR GCP training, you'll be able to find a portal that will be able to take you to do a couple of hours of online training to get a GCP certificate. This is an important competency, and I think it's increasingly recognised as an RCPCH competency within training. So that's how you can get involved in research that's ongoing, national research that's ongoing. Just a kind of brief run through there, and then probably in the next 5 or 10 minutes, I'm just going to quickly give you a whistle-stop tour of how you might want to develop your own research ideas. This, I think, is not impossible. I think it's really essential to advance paediatric and neonatal care generally, and I'm going to just talk about some ways you might want to do this. First, can conduct your own study. This is quite challenging. You can build a study using some existing resources. The British Pediatric Surveillance Unit is an excellent example of that. Or potentially you might have a question that is a really important burning question that needs a big clinical trial. And clinical trial units are very keen to work with people to develop these. And often questions and ideas that come from clinical people are exactly what the NIHR is looking to fund. I think it goes without saying that all of these take a lot of work, but are potentially very rewarding, both just in kind of general life, as in trying to answer a question that was unanswered in the past, which I think is one of the reasons we are involved in research, but of course also for your CV and your personal advancement. So, conduct your own study. This seems impossible, doesn't it, really? But it isn't. And I think there's a lot of generally quite small scale studies out there, which may be observational, questionnaire-based studies that are really important and add to knowledge or often underpin larger pieces of research. There's important questions, I think, to consider at the beginning about statistics and design and how you're going to analyze anything you do. And those can very much be ironed out by talking to more experienced people within your group, within the pediatric community where you work. There will often be people who have considerable research experience, certainly at some of the larger hospitals. You need to consider who might act as the sponsor, which has a very specific legal role. It's usually quite straightforward at big university hospitals, but even smaller hospitals will be able to act as sponsor for smaller studies. And there may well be approvals like research ethics committee approvals that need to be obtained. And again, support from local R&D departments is important to do that. And I think the NIHR have a research design service. We're very good at supporting and providing methodological feedback about proposals for research. But I think overall the key role here is if you're considering something like this, if you're interested in doing this kind of work, you need to be aware that it probably will take quite a lot of time and quite a lot of work. And the support of somebody who's experienced in navigating the system is really critical to this. So try and find an experienced local researcher. They're often time poor, so you kind of have to persevere at it in convincing them that you are actually going to see through what you say you're going to see through. But they will be really helpful in getting you to do that. And then just towards the end here, another couple of minutes on a couple of specific ways that you may be able to undertake research. One of these, which I've worked with before, is the British Pediatric Surveillance Unit that hopefully you all know about. It's over 30 years old now, and it is really recognised as the gold standard way of undertaking population level surveillance of rare conditions. It was the world leading the world leading surveillance unit when it was established 30 years ago. And originally it relied on what was called an orange card, which was literally that. It was sent round to all paediatricians who'd reached consultant or equivalent status every month. And on it, it had a list of conditions, and it said, have you seen any of these over the last month? And it also asked you very specifically, if you hadn't seen any, to also tick it. And it had a stamp on the back, and you just sent it straight back to the BPSU. And that's called active surveillance. So you're telling people if you've seen something, but also if you haven't seen something, so they can work out what proportion of responses they've had. And then a further questionnaire would be sent out if you did report that you had seen a case. So I'm currently running a BPSU surveillance project looking at neonatal COVID, SARS-CoV-2 infection, but of course there's been a whole host of other ones around multiple other conditions, Group B strep infections, for example, babies with low APGAR scores at 10 minutes, severe chronic lung disease was another one that was recently published, and they're not all neonatal, so of course there are some pediatric ones in there as well. It is all run through the RCPCH, and they have a fantastic set of web pages to guide you through the process of thinking about a project and applying. And there is an application process that provides money to pay for 1 year of surveillance. So it costs around £15,000, and there is a bursary called the Peter Tizard bursary that provides money to do that. It's quite competitive, but every year somebody does win it to undertake a BPSU surveillance project. So a fantastic way to undertake a research project, to work with other people across the UK to build and develop such a project. I'm a little bit biased here. I work very closely with the National Neonatal Research Database, which is based at Imperial College London. It holds data from all neonatal unit admissions, drawn largely from BadgerNet, but increasingly from other EPR providers. There's a paper that I've wrote, as you can see here, in Archives, Education and Practice, about how you might want to use that data. And there's a very clear process on the website at Imperial. If you type in using the NNRD, you will be taken to that webpage that can just talk you through that. Again, there's a small cost for data extraction, but it's, again, something that we're trying to encourage people to undertake clinically based research using this kind of process. And then finally, if you do decide that you want to undertake a very large project, if you decide the only thing that we can do is a national study, then clinical trials units are probably the place to go to start those discussions. They provide expertise in statistics, methodology, and particularly in the management and how to apply for money. And they are fantastic at getting regulatory compliance and going through those hurdles. Again, there is a paper I wrote in Archives a few years ago about how you might want to work with a clinical trials unit if you are thinking of doing that. And yeah, there is a process. You have to pitch your idea. It will be competitive. There'll be lots of other people with good ideas, but you need to persevere and continue at it. And I'm just trying to think if I have it here. No, and so there's some good examples here of trials recently which have been undertaken by trainees. So there's one that is called Minidex, that was undertaken by Helen Yates when she was a neonatal trainee, looking at dexamethasone. And it was an NIHR funded pilot feasibility study, which unfortunately showed it wasn't very feasible to do low dose dexamethasone for chronic lung disease. But it was a very well run trial and found an important answer, which is that we couldn't do a bigger trial. And then another one called NeoClear, which was led by Charles Raw, but was established and developed really by Andrew Marshall, who again was a pediatric trainee and still is, and has really been led by Alex Shrivens, and I'm sure many of you have worked and have met them as part of the trial. And that trial, the results have been published, or not published, presented at a couple of recent meetings, and will hopefully be in a very big journal coming forward. And I think will change practice around how we undertake lumbar punctures in neonates, for example. But those are two really good examples of trials that have been developed and led by trainees. So it's absolutely feasible and possible. Research is really about money to some degree. The NIHR recognises that, and that's why a lot of research recruitment and things are tied to money, and that's why it's so important for trusts, which is great. It's raised the profile of research dramatically. Getting money for you, for your individual research project, is a massive challenge. I'm not going to kind of understate that. Again, people who have done it locally will be able to help you. They'll be able to put you in the right direction. And there are lots more sources of funding than I think most people recognise. There will often be local hospital charities that will fund some research studies, and there may be disease-specific small charities for your particular immunoglobulinopathy, for example, that may provide funding for that particular niche area. There are existing resources such as the beta-TISID bursary, for example, for the BPSU. And then if you want to take a large clinical trial, there are several funding schemes run by the NIHR. And there's a particular one called Research for Patient Benefits, which is very squarely targeted at early career researchers. And it provides funding at either 150, 250 or 350,000 pounds for smaller studies, feasibility pilot studies, to lead potentially to bigger studies in the future. And again, very happy to help people provide advice around that. I sit on one of those funding panels, so we see the applications that come in from the other end. But it's really important that you work with a clinical trials unit around developing those, or at least with the NIHR Research Design Service. And the other important paediatric research charity is Action Medical Research for Children, which do also provide quite sizable grants to support fellowships and research projects. And there is also RCPCH resource developed to provide a whole list of different research funding opportunities. The NIHR has a whole host of other ones. The biggest, I guess, most well-known is the Health Technology Assessment Programme, which provides funding for a lot of the very big trials out there. But there's a whole host of other ones within that. They are massively competitive, but will potentially provide a large amount of money. But again, work with a clinical trials unit and with experienced researchers. So that's a whistle-stop tour. I haven't talked about the ways that you manage people within research. I haven't talked about the theory of management or how that applies to research. I find those a little bit dry, but I'm very happy to talk about my experience if people have questions at the end here. I'm going to leave you with this slide. I think this is about neonates, but I think we could equally apply this to pediatrics. Neonates and pediatric care is important. Within neonatology, 1 in 8 babies will require it, and nearly half of all children that die in the neonatal period. But despite that, most of what we do in neonatology is not actually based on high quality trial evidence. It's not as well evidence-based as we'd like. I think we need to highlight and resolve this uncertainty. It makes us better clinicians to do that, and of course improves the care we provide to the babies we look after. And I think you as clinicians, in particular you as clinicians in training, have first-hand experience of some of the variation that we maybe miss as we become a consultant and stay confined often to one unit, one paediatric or neonatal unit for the rest of our lives, or certainly for a longer period of time. So you're aware of the different uncertainties that maybe we've forgotten about and how they might impact on pet care, or how they just represent the fact that we are providing unequal care, and maybe we should formally randomize those uncertainties in order to understand which one works better. So I'd strongly involve you to get involved in research. It's clearly a academic competency within the RCPCH curriculum, so you do need to for that purpose as well. But it's also potentially very interesting. I find it very rewarding. I certainly love the fact that I have a research component to my job. And I'm very glad that I made that decision at kind of ST4-5 level to undertake an MSc, and enabled me to do that going forward. So thank you very much. I'm a bit over time, in part because of my technical incompetence at the beginning, but hopefully people might have the odd question.
Thank you ever so much, Chris. Yeah, no, it's really nice hearing you talk, actually, because I think something that I've faced, and I don't know if others have faced as well, is that we do these 6 monthly rotations, and often the only time you really get to expose to research is in your tertiary jobs. And that can be sometimes a difficult thing in a DGH, is knowing what good research looks like and how to get involved in kind of such a short period. I don't know if you have any particular advice for that.
I mean, the reason I'm doing research, to be honest, is because I had a really interesting time at a DGH, which will remain nameless, when I was doing my ST4, and I'd gone from a big job at the Royal London, and it was very evidence-based, all of the things we did, and then I went to this small DGH where practice was just wildly at odds with what I'd been taught, and it was very variable between different consultants, and I tried to challenge them around why they were, diagnosing asthma in a 3-month-old, for example, and they really kind of threw it back in my face, and that made me realize that it's all grounded upon the evidence that you use, and that actually the quality of that evidence isn't great. And that made me want to do an MSc, like I say, just to really understand how to argue better with the people that I wasn't sure I agreed with. So I think sometimes being exposed to research and that research culture in different ways is quite formative and quite useful. I think having the kind of knowledge up your sleeves that there are ways to engage in research management, certainly through this Associate PI scheme, or when you are working at a big hospital where there are those opportunities and where there are trials running, where there is a local PI who would love, I expect, for somebody to come along and take on some of that workload for them and also get some training. And if you're at a smaller unit for a long period of time, you know, I think often they do want to be part of research because there is a kudos associated with it for the trust and for the department. But often people just don't have the time amongst everything else to do that, where they might do a larger academic centre. So if you are at a site for a year or so, it may be that you can start to put in place the ability to take part in a trial, or you can certainly ask around about it and find out if there are trials that people are considering doing that you could maybe be part of driving forward. And I know at the Homerton, for example, there's been several trials that have basically been, you know, have been run by trainees, even if previously there was one of the consultants' name on as PI. So there's great opportunity to do that, I think. I don't know if that answers your question. I think you asked me a slightly different question, but I've kind of...
No, that's really brilliant, actually. And it's actually nice to hear a different perspective and thinking differently and thinking how to make use of the opportunity. So thank you. We've got a question from Abdi. I'm happy to read it out, Abdi. You're welcome to unmute. But he says, thank you for the talk, Dr. Gale. I was wondering what your thoughts are on clinical research fellow posts. Do you feel that they provide a good transition into research for those who are absolute beginners?
Yeah, I mean, I think the devil's always in the detail. So I should put these slides in really. I didn't think I'd have time, but yeah, so I had my experience of realizing that research guided things and maybe I needed to know how to better do it. And then from that, I did a clinical research fellow post, and I worked at the Portland for the first 6 months, which was an interesting experience, but it funded the research that I did, and I did a cohort study as part of my PhD, which gave me a really nice grounding in research, very different from what I now do and what my now interest is, but without it, I certainly wouldn't be here. So I think clinical research fellow posts can be fantastic opportunities. Some of them are just perfect, and they are brilliant, and they are really interesting, well-resourced projects that, you know, are just a dream. Those are pretty rare generally. Often they are a little bit less structured, and often people will ask you to try and develop a research idea which gives you freedom to focus on something that you want to focus on, but also is a bit of a challenge because often you don't know where to start, and you need a kind of iterative discussion and an iterative process to do that. I've had two clinical trainees recently. One is a neonatal trainee up in Birmingham called Tim Van Hasselt, who was just funded the other day for an NIHR clinical research fellowship. So, and he's developed that project entirely really on his own with a bit of guidance and support from myself and some people in Leicester. And that's looking at the transition between neonatal care and pediatric intensive care. And that's been driven very much by his own clinical experience. And we built a really nice project out of it. Well, he did really, not me. And he's been funded, and he's now doing that for the next 3 years. So that's kind of the dream, I think. That's the way that is the optimal way to do it. Often a clinical research fellow post in an unstructured post, like some of the Portland posts we have here in London, will give you the opportunity to have 6 months to try and develop that in a way where you're not focusing on your clinical training. So I think they can be really good. I think it's often about the supervisor that you have. I think it's really important to try and find a supervisor that you work well with. I think some of the most eminent people are often the busiest. So it depends a little bit on the project and what kind of worker you are. But you can usually find people who have experience of working with academics who will tell you, if you buy them a coffee or something, what it was like to work with that particular academic, and whether it's something that, you know, so you can go into it with your eyes open a little bit more. I think the other thing to say is, as someone on the other end of it now, as people come to me and ask me about projects, lots of people will come and find you and ask you and say they want to do research, and probably only 1 in 10 of them will actually see it through in any kind of way. So you need to persevere, I think, because you need to convince that person that it's worth them investing the time in you, that you're that 1 in 10 who will actually go on to undertake a research project with them. So that's it summed up. So find out who the supervisor is. I think they can be fantastically important and useful. You don't need to do them. You can do it without, but it is a bit more challenging. Make sure it's the right supervisor. The project is important, but often the project is defined a little bit about the art of the possible. So it probably isn't going to be the project that you want to do necessarily, but it may well turn into the project that you really enjoy doing. Clearly, if you hate being in the lab and it's an entirely lab-based project, then that's probably not for you. But beyond that kind of thing, you can normally work out, you can normally find a way to make the project your own, I think, as it evolves and goes on. But yeah, I think they're really important, and I think they're a great way to get research experience.
Thank you very much. We've got another question. Hopefully, Abdi, that answered your question. Claire's asking, thank you for the talk. I was just wondering if there are any paediatric trainee networks that carry out multi-centre research that we can get involved in? And do you have any tips for getting involved in writing case reports?
Yes, so there's lots of multi-centre. Is this just a London meeting? It is, isn't it? It's London School of Pediatrics.
Yeah, London, yeah. Well, I don't know everyone in this group, but I'm assuming it's mostly London trainees.
Mostly
yes.
London, yeah. Although these days everything's slightly online, isn't it? So yeah, there's NeoTrips, which is the London-based neonatal group. There's PRAM up in the West Midlands. There's a few of them around, and I think on the RCPCH website there is a web page now which kind of links to them all. There is obviously Peruki, which is the kind of paediatric emergency care research group as well, who do some really fantastic pieces of work, fantastic research studies and research trials. So there's lots of these groups out there, and I think they are a really great opportunity to get involved in multi-centre research that's trainee driven. So NeoTrips, my colleague Cheryl is very active and involved in, although it is very much driven by trainees, and they're looking at, I think, they're looking at MIST and LISA, so non-invasive surfactant delivery, I think, is their next project, and they'll be looking to do that across multiple sites in London, looking at multiple neonatal units. So a great opportunity again to get to credential, to get a little bit of research experience and see whether it's something that you're interested in. Selena's just put it on, so there you go. Those are fantastic.
Dr. Gale. Oh,
yes.
Sorry. Apologies for interrupting, but it might be a good time to interject. So sorry for everyone. My name's Rob. I'm one of the academic trainees in London. In the similar vein to PRAM and some of these other networks, there is in the very imminent future coming a London-based network of quality improvement, audit and multi-centre research. It's going to be called, or it's called REACH. We're just in the sort of setting up stages now. So what I just wanted to say to Claire is if she has got ideas for projects, we're going to be looking for pilot projects in the coming months. And if she wants to send me an email or just keep an eye out for on the LSP website, there will be a sort of a call put out for primary project ideas for REACH's first pilot project. So I just thought that would be a good moment to mention that. Apologies for the interruption.
No, please interrupt away. I love it. And I feel really bad because I remember voting for the name for REACH, and so it should have been at the on the tip of my tongue, but I apologies for not knowing that. But no, brilliant. And I think that again, it's just an example of how this kind of trainee-led research is really starting to snowball. And I think the other thing to say from a slightly more mercenary point of view is the surgeons have been doing this for years and have had some fantastic publications in the BMJ and things at their surgical trainee delivered research projects. So, there is real scope to change practice and, through really high quality publications. Case reports, I think, are really important. I think they get a slightly bad name. They're a good way to get a paper. They're often not as simple as you think they might be. There is a really great journal called BMJ Case Reports now, which runs a kind of subscription type model where you kind of join it and they provide lots of support and advice in getting case reports published. That's one way, and I think there's quite a lot of resources on there, and your library may have a subscription to that, so it's worth kind of going down there and exploring that. I think the one at Chelsea does. Or the university if you're allied to a university. I mean, otherwise, I think the things to think about with a case report are to just keep your eyes and ears open. And often at tertiary centres in particular, cases that are suitable for case reports come through relatively regularly. It's just people don't have the time to write them up. You know, it needs to either be a kind of novel presentation, a novel kind of disease, a really rare disease, or a novel presentation of a common disease, or kind of two kind of rare things or one quite rare thing in the same patient. Those are kind of often the way that it's the kind of hook that journals are interested in, or a novel treatment for a more common disease, or potentially for a rare disease, but some kind of new approach to treatment. And of course, images are quite good. So if it's a novel image, Archives has its kind of images in pediatrics. They have a couple of those each week, each month. So that's another good way to get case studies and case reports in there. But yeah, they can be really good. You need to get consent while the patient's on the unit, ideally. But families, in my experience, are pretty happy and pretty keen to grant that and give that. I would also suggest finding people within the unit who are experienced and have written them before, if you can. And you know, as long as you make it clear that you're going to do most of the work, most people are pretty keen and happy to support you in that process. And there you go, Selena's put it up for us as well. So I think case reports are really good. The other way to get a publication that's quite nice is through one of these clinical evidence summaries. So for example, Archives do Archimedes, which I would strongly recommend reading, and I always read it every month. I think it's fascinating. And that's where somebody's like taken a clinical question that they've come across in clinical practice. So the one I did years ago, my first ever publication, in fact, was around when I was on neonatal transport, was saying, does capillary full-time work in babies, in preterm babies? And you know, you form it into a PICO question, and then you do a review of the literature, and then you try and apply that, and you do a critical appraisal of that and write it up within about 1,000 words, I think 500 to 1,000 words. Bob Phillips, who previously used to run that, I think still does, is very good at providing feedback and helping you craft it into something that's very publishable. So that's another really nice way to get a publication in pediatrics in a top quality journal in Archives. So those would be my top tips for low-hanging fruit, if you like, for research publications. Any other questions?
Anyone last minute would like to say anything or ask any questions or put anything in the chat? I think that's probably it. Just an enormous thank you again, Chris. Thank you ever so much. And please, I'm going to put the link in for feedback now. Please send